Get away from the excitement of looking at ASOs and come back to basics, I'm afraid. My name is Martin Lavin, and I work with Dave Coleman, who you've heard about the clinical trial we've been conducting on C7. And I'm replacing Yossi Shilo to tell you about the highlights of the meeting that we've just had. The focus I was asked to concentrate on was the ATM protein. In other words, looking at the basic mechanisms that are involved and things like that, because there were sections in this meeting which covered the molecular side of it as well. Of course, we interface with the clinical side, which is obvious from the clinical trials we've carried out together. You've heard some very exciting sort of developments in clinical trials, all the way from encapsulation dexamethasone to nicotinamide riboside, C7 with us, and nicotinamide, or the N-acetylleucine as well. You've seen some of the limitations, as Tim pointed out there. You know, it's a smaller percentage of the AT group that actually are going to respond to these. And I think there was a question down there about would a truncating mutation be receptive to this? And I think, as Tim pointed out, the answer probably is no at this stage, but on one of his slides, he showed a picture of someone who's been very strong in the field of AT research, and unfortunately is not here today, and that's Dick Gatty. He's been associated with AT for many years, and they've been developing compounds called read-through compounds, which actually can go across the top of his top mutation. I'm not sure how much further they've gone with it, but they have compounds that look promising and so on. So that would be one way to address the truncating mutations. So I just want to put it into perspective in terms of history as well, so because maybe not all of you are familiar with all the changes that have gone on. Next year is an important year for AT because it's exactly 100 years ago since the first patient was described. And at that time, there were symptoms, but it wasn't a syndrome at that stage. It took another 30 years before Helena Boder and Robert Sedgwick actually described patients and established a syndrome at that point. So that's 70 years ago. There's something else that you should be aware of. It's now late June. Your meetings are held along the East Coast or East Midlands here, all the way down to Luton and that. And I've attended some of these, and they've been very successful, where we've brought together the community, the AT children, parents and researchers, clinicians, scientists, and so on. So does anyone know what happened 30 years ago about this day? The gene was discovered. So it's exactly 30 years almost to this very week since the ATM gene was described. So since then, there's been important improvements, because once you've got the gene, of course, then we're able to go through all this sort of data you've seen here about predicting mutations and all that and so on. And that's been very important because the nature of the mutations have been described. They're related to the various susceptibility to develop tumors and so on. And that's an ongoing sort of discussion about mutations. One limitation, of course, even when you have the gene, is being able to diagnose a child at the appropriate time. Because while you may have mutations, then unless you have some way of testing for that initially, for example, if you have a sibling who has the disorder, then you can actually test for that quickly. Otherwise, you have to rely on, the neurological symptoms developing. But at this meeting, and this has been described for some time now, there are methods for rapid diagnosis as well, indirect maybe, and they rely on this great multitude of characteristics that we see in AT cells. I'm referring specifically here to the immunodeficiency, because there is another syndrome, severe combined immunodeficiency, and AT has some overlap with this because there's a simple assay there. AT patients have a low level of this TREC, which was referred to actually, I think, here on one of these slides, so that you can do a check this way, but that hasn't been established or haven't been introduced for AT patients yet, but it's certainly been done among some patients, and it represents a quick way for diagnosis, and that came out again in this meeting here. Clearly, having the gene is going to be important, as we said, for diagnosing patients and for relating to specific phenotypes and so on. But it's important for us as well to have the gene to be able to find out what it really does and so on. And that runs in parallel clearly to any other use of the gene. You've heard reference, I'm sure, many times that the ATM gene is primarily involved in repairing or recognizing damage in DNA. So if you get damage in DNA and it hangs around, then there's a propensity to develop mutations and develop tumors and other pathology as part of the AT phenotype. We've seen from the work during the week, and I want to not pick all the talks we had, but one example from Peter McKinnon, who's worked on AT for a number of years. And what he was able to do, I should backtrack a little. A number of animal models, other models have been established for children with AT. The problem with all of those, while they recapitulate a lot of the phenotype, you do not see the neurodegenerative phenotype in these animals. Now, Peter and people like that have got around this. So what they do is they establish a mouse model, put a mutation in so that that carries damage. So the mouse model has nothing to do with AT at this stage, it's carrying damage. But if you then go in and take the ATM gene out of the equation as well, then you begin to see the ataxia phenotype. And they've got down finally to be able to look at specific mechanisms and so on. And this is going to be very useful to look at use drugs as well for correction. Kim Chow spoke to some of you yesterday evening, and she raised the issue of energy metabolism. And this brings in another aspect of AT. I mentioned that ATM is important in DNA damage response, responding to the lesions and so on. But more recently, as you've heard in some of the clinical trials, there's been a component of defect there, namely the mitochondrion. So mitochondrial dysfunction is becoming an important part. It's observed many times, and we've now narrowed it down to the stage where there are abnormalities in energy metabolism. And Kim spoke about this yesterday evening and so on. And how are we addressing it? Well, you've heard from Dave that one of the ways we've done that is by coming up with molecules that are able to address that energy deficit. For example, in our particular case, there was a molecule called C7, and that's able to put new substrates, new fuel into the TCA cycle, which is responsible with the electron transport chain for generating ATP and energy. So if you're able to correct that downstream effect at the level of the dysfunctional mitochondria, then you have another mechanism to address the abnormality. And I said there's a number of clinical trials going on to address that. How much time? Am I running out of time? Or 5 minutes? Oh, okay. So then coming, how you actually extrapolate from that defect in energy metabolism is difficult, because if you look at patients, we've heard many times fatigue is a big problem. So can you actually then say that what we're seeing in a cell applies to patients? Probably not, because we know that in patients' cases there's going to be muscular problems, there's going to be fatigue from all that as well. But by understanding at the level of the cell where the difficulty is in energy metabolism, then we can perhaps correct that. And I think we have evidence for that as well with C7, for example, where patients, at least some patients, 50% I think, responded, who improved not only things like swallowing as well, but their energy capacity increased as well. So that's very hopeful, I think, there.